like schizophrenia, depression, anxiety, okay, bipolar disorders, okay, and antipsychotic drugs are the drugs that mainly treats the schizophrenia, okay. So, as for classification, okay, antipsychotic drugs can be classified according to the chemical structures, okay, like having phenothiazines group of drug, okay, beta-arphinones, okay, and then okay, antipsychotic drugs are the phenothiazine group of drugs. There are phenothiazine group of drug, beta-arphinones group of drug, okay, and then there is a then there is a thiaxanthines and heterocyclic drugs, okay. These are the typical antipsychotic drugs, okay, or also called first generation antipsychotic drugs. These drugs mainly, as per mechanism, they mainly blocks the D2 receptor in the mesolimbic system and thus have an antipsychotic effect, okay. And yesterday we have discussed as a chlorpromazine as a prototype drug, okay. The mechanism of actions of this typical antipsychotic drugs are similar, only their properties, okay, pharmacokinetic properties, and some of the actions of these different drugs will differ with their potency also, okay. There are higher potency antipsychotic drug and low potency antipsychotic drugs, okay. So as for mechanism of actions, these drugs, they are typical antipsychotic drugs. They mainly blocks the D2 receptors in the mesolimbic area and have a antipsychotic effect, okay. Apart from having these actions of D2 blocking in the mesolimbic system, they also blocks the other D2 receptors in the other dopaminergic neurons or in the other dopaminergic pathway, like in cases of nigrostriatal pathway that mainly cause one of the main cause for the extrapyramidal symptoms. Yes, so there are different types of extrapyramidal symptoms, like one is the most common is the Parkinsonism-like symptoms, right? Then there is a tardive dyskinesia, okay? Then akathisia, others like acute muscular dystonia and malignant neuroleptic syndrome, okay? These are the main adverse effects of the typical antipsychotic drugs. And then we have got other group of drugs, that is the atypical antipsychotic drugs, okay? So we have already discussed about the chlorpromazine. Now we'll discuss the other drugs in brief, okay? Next drug is thiazidine, which is the low potency antipsychotic drug, which has a high anticholinergic effect with less in this among these atypical antipsychotic drugs, okay. Thiazidine has a less extrapyramidal symptoms. It can cause cardiac arrhythmia and can interfere with the male sexual functions, and in long term they can also cause eye damage. So next is the high potency antipsychotic drug, okay, in which we have got trifluperazine, promazine, fluphenazine, haloperidol, and others, okay. So trifluperazine, again, it is mainly used as for the antiemetic effect, okay, due to its D2 blocking action. Fluphenazine and this trifluperazine, they have got the minimum autonomic actions, okay, and fluphenazine, because of it can be given as intramuscular injections, it is given for the uncooperative psychotic patient. Haloperidol, okay, which is the most commonly used mainly in cases of acute schizophrenia, okay, and other schizophrenia, okay, which is high potent antipsychotic drugs. This haloperidol has a less autonomic effect, that is the alpha action and the anticholinergic action, and also it is less epileptogenic, okay, and it does not cause weight gain and jaundice, which is very rare. And haloperidol is a preferred drug for the acute schizophrenia, Huntington's disease, and for the Gilles-de la Tourette syndrome. Okay, these again both are these are different type of psychiatric illness. Okay, Huntington's, it is a inherited disorder. Okay, where there is a cell death of the brain. Okay, causing problem in mood disorder and mental disability. Then similarly, Gilles-de la Tourette syndrome. It is again a different type of psychiatric illness, which is mainly seen in the children having different activities. Okay, abnormal activities like eye blinking. Okay, continuous eye blinking, then coughing, that throat clearing. These two types of symptoms that are seen in case of children, which is called as Gilles-de la Tourette syndrome. Okay. Next is the penflurodil, which is a long-acting neuroleptic drugs. Okay, used mainly for the chronic schizophrenia. Pimozide, it has a selective dopamine antagonist with little alpha-adrenergic and cholinergic blocking activity. Okay, having long duration of action and is used mainly for the maintenance therapy. Okay, so those are the few properties of the typical antipsychotic drugs. Okay, so mechanism of action of typical antipsychotic drugs are almost similar. Okay, you need to compare with this typical and atypical with the different properties like extrapyramidal, having extrapyramidal symptoms. Okay, or having sedation action, then hypertension action or antiemetic effect. Okay, that you can compare the properties of the different antipsychotic drugs. So now let's go with the atypical antipsychotic drugs, or also known as second generation antipsychotic drugs. Okay, atypical means these drugs they have got the less action on the D2 receptors. Okay, so these are the newer antipsychotic drugs having high potent serotonin antagonist action, that is in the 5-HT2. It also blocks D4 receptors. And atypical antipsychotics drugs, okay, it has been found to be effective in both negative and positive symptoms of schizophrenia. Okay, so negative symptoms means, okay, this usually there is a poor socialization. Okay, then emotional blunting. These types of symptoms are the negative symptoms. Okay, having lack of motivations, whereas positive symptoms, usually patient will have a delusions symptoms, hallucinations. Okay, mainly the auditory hallucinations that is seen. Okay, or garbled sentences with irrational conclusions. Okay, this type of symptoms are the positive symptoms of the schizophrenia. So atypical has effect on both negative and positive symptoms, whereas typical, they mainly resolve the positive symptoms. Okay, and also the relapse of schizophrenia, symptoms of schizophrenia is less with the atypical and more with the classical antipsychotic drugs. So apart from blocking the serotonin and D4 receptors, it also blocks other receptors in the brain like alpha receptors, muscarinic and histaminic receptors, and has a weak action on the D2 receptors. So there is a minimal extrapyramidal side effects. Okay, however, it has a high risk of metabolic side effects like diabetes, hypercholesterolemia, and weight gain. That is the main adverse effects of the atypical antipsychotic drugs. Clozapine, okay, it's the first atypical antipsychotic drugs having the blocking action on the serotonin receptors. Okay, major action on the serotonin 5-HT2A, then D4, and lesser with the other receptors like alpha-1, D1, D2, histamine, and muscarinic receptors. Okay, in the brain. So due to its less D2 blocking action, it has a few or no extrapyramidal symptoms like tachycardia is also less, and also it does not increase the prolactin level. Okay, so the properties that we have already discussed in general of atypical also apply to the clozapine. Like it also improves the positive and negative symptoms of the schizophrenia, used mainly in the refractory case of schizophrenia. Okay, where the schizophrenia could not be treated with the typical one. Okay, and this clozapine has found to be also quite sedating and has a potent anticholinergic action. So adverse effects of clozapine, okay, it can cause a granulocytosis, okay, then weight gain, hypersalivation, okay, it can decrease the seizure threshold, that means it can increase the risk of epilepsy, okay, then precipitate the diabetes, sedation, okay, there is unstable of blood pressure with tachycardia and can cause urinary incontinence. Next drug is the olanzapine, again having major action on the serotonin 5-HT2A if you compare with the other receptors, okay, more action with the serotonin and D4 receptors. Others are similar to the clozapine, properties are similar to the clozapine, but it does not cause the granulocytosis. Risperidone, again similar property, okay, having more with the serotonin and D4 receptors, action on the serotonin and D4 receptors, okay, more potent to D2 blocker than the clozapine with less, okay, extrapyramidal effect are less with the low dose, okay. It is less epileptogenic and there is a less risk of weight gain and onset of the diabetes, okay. And also it can cause hyperprolactinemia, okay. Though the mechanism of actions, it's the mechanism of, excuse me, yes, who is talking between the class? Please mute yourselves. Please check your mic, okay, everyone. Okay, so that was about the risperidone, okay. Now next drugs is the quetiapine, okay. Okay, first aripiprazole, okay. Let's go with the aripiprazole. Aripiprazole, which is a newer agent having a novel mechanism of action. This has a partial agonist action on the D2 receptors and serotonin receptor, while antagonist action on the 5-HT2A receptors, okay. It is non-sedating with a low extrapyramidal symptoms and hyperprolactinemia, and there is no anticholinergic effect, okay. So there is a novel mechanism of aripiprazole having partial agonist on D2 receptors and serotonin 5-HT1A receptors, okay. So with this mechanism also it has been found that it has a antipsychotic effect with less extrapyramidal symptoms. The frequent side effects are the dyspepsia, constipation and lightheadedness. So next drugs are the ziprasidone, okay. So it also blocks the serotonin receptors more than the D2 receptors and alpha-1 and antihistaminic receptors. Sorry, and histamine receptors, okay. So it also inhibits the serotonin and noradrenaline reuptake. That mechanisms of this also have indicates of having anxiolytic and antidepressant actions, okay. In antidepressant, most in the antidepressants of drugs, okay, they mainly inhibit the reuptake of this serotonin and noradrenaline that will cause the antidepressant properties. So ziprasidone also has to be found with of the anxiolytic and antidepressant action, okay. And this also has less extrapyramidal symptoms with less hyperprolactinemia, and there is no anticholinergic side effects, okay. So adverse effects of ziprasidone, it can cause nausea, vomiting, okay, which are the common side effects. It can cause moderate hypotension, weight gain and increase in blood sugar level, and can cause QT prolongation. Next is the amisulpiride, okay, which has a high affinity for the D2 receptors and also the D3 receptors, but it has a less extrapyramidal symptoms, okay. So it's not in the typical antipsychotic drugs. They improve the negative symptoms of the schizophrenia, and also has been found to have antidepressant actions, and it is non-sedation. Okay, so there is also the advantage of this new drug is also that there is a low risk of weight gain and metabolic complication. Okay, however, as an adverse effect, it can cause hyperprolactinemia, insomnia, anxiety, and agitation, and can increase the QT interval. Okay, so that was about the atypical antipsychotic drugs. Okay, now next is the drug interactions, which is very much common. Okay, these antipsychotic drugs, they blocks the action of levodopa. Okay, it can potentiate the other CNS depressants drugs like hypnotics, anxiolytics, okay, alcohol, opiates, and antihistaminic drugs. Okay, the action of clonidine and methyl dopa is reduced because of alpha adrenergic blocking action. Okay, and drugs like barbiturates and anticonvulsant drugs, which are enzyme inducers. Okay, they can reduce the level of neuroleptics. Now, uses of antipsychotic drugs. One is in cases of schizophrenia. Okay, so the treatment, the goal of treatment is to relieve the symptoms of schizophrenia, functionally rehabilitate the patient. Okay, so they are mainly these drugs are mainly the symptomatic treatment. But if there is any cause of the symptoms, okay, the cause has to also be removed, okay, or treated. So usually the choice of the drugs is usually by the presenting symptoms, okay, its associated features and this mood state of the patient, and also we must always go for the side effects or contraindications of the with the patient. Okay. So usually for the treatment of schizophrenia, okay, usually the newer atypical antipsychotics drugs are preferred, okay, having less side effects and neurological complications. And also the advantage of atypical antipsychotic drug is that it can control the negative symptoms. Okay, so the choice of drugs, as I have said, okay, there is a choice of drugs is according to the symptoms of the patient. Okay, like for example, if the patient is agitated, combative, okay, then violent, then usually the drugs of choice are the haloperidol, quetiapine, okay, chlorpromazine, and thiridazine. Okay, so next is the in cases patient having withdrawn or apathetic conditions, okay, in those trifluperazine, flufenazine, aripiprazole, and ziprasidone are the choice of drugs. Next indications, okay, like patients having mainly the negative symptoms, and in cases of resistance cases of schizophrenia, clozapine, olanzapine, risperidone, aripiprazole, and ziprasidone are given. Okay, then patient with mood elevation and hypomania, haloperidol, flufenazine, quetiapine, olanzapine is given. Okay, if extrapyramidal symptoms are to be avoided, okay, thiridazine, clozapine, and other antipsychotics drugs can be given. In elderly patients who are prone to have sedation, okay, mental confusion, and hypotension, again hypotensive, phenothiazine drug like triflufirazine, okay, flufenazine can be given, and also haloperidol and aripiprazole are the drug of choice mainly for the elderly patients who are prone to have sedation, hypotension, and mental confusion. So you can see, okay, the choice of drugs depends mainly on the symptoms of the schizophrenia. So one of the main indication of the antipsychotic drugs is in cases of schizophrenia. Next indication of these antipsychotic drugs is the in cases of mania, which is another psychiatric illness in which there is an irritable mood. Okay, so high dose of antipsychotic drugs are required mainly to control the acute mania. Usually chlorpromazine and haloperidol can be given. Okay, and atypical antipsychotics are given in patients where there is no need of the urgent control of this acute mania. Okay. The next indication in cases of bipolar disorder. Okay, so as you know, bipolar is a cyclic episode of mania followed by depression with period of normal mood also. So here again the drugs are the tricyclic or selective serotonin receptor reuptake inhibitors, antidepressants drug. Okay, these are the drugs that are given for depressions with low dose of antipsychotic drugs. Okay, usually again here in bipolar disorder, atypical antipsychotic drugs are given, and quetiapine is the preferred drug, which is effective as a monotherapy also. Next, organic brain syndrome. Okay, that means again the psychiatric illness due to any cause of in the brain. Okay, like for example overdose of the drug, infections. Okay, so here low dose of antipsychotic drugs like haloperidol, risperidone, aripiprazole, and ziprosodine are used for the management of organic brain syndrome. Now next is a general consideration with antipsychotic drugs. Okay, so while using antipsychotic drugs, we have to always titrate the dose, okay, with the symptoms, and to keep the dose of the drugs at a minimum level. Okay, usually one drug should be given. Okay, monotherapy should be done instead of giving 2 or more drugs. Okay, and to see the therapeutic effect of the drug, it usually takes about 2 to 4 months. Okay, and to control the exacerbations or violent behavior in schizophrenia or mania, usually haloperidol and chlorpromazine can be given by intramuscular route. Now next indication of antipsychotic in anxiety, but again nowadays benzodiazepines are more safer. Okay, so usually benzodiazepines are more preferred in anxiety. Okay, they are less commonly used because of this psychomotor slowing, okay, emotional blunting, and autonomic and extrapyramidal side effects. Okay, however, in anxiety, low dose of quetiapine, risperidone, olanzapine can be given as an adjuvant to the antidepressants drug like SSRI, which is a selective serotonin reuptake inhibitors. Next indication in cases of for vomiting, okay, as an antiemetics because of its D2 antagonist action. Okay, though however there is newer antiemetics drugs which are more effective and having less side effects like serotonin antagonist are used than the neuroleptics drug. Okay, so this type of D2 antagonist drugs, okay, they can be used in drug or disease-induced vomiting. Other indications of antipsychotic drugs to potentiate the hypnotic effect, analgesic and anesthetic action. Okay, it can be used in the intractable hiccup. Mainly the drug of choice is chlorpromazine. In tetanus, again chlorpromazine, and other indication in cases of alcoholic hallucination, Huntington's disease, and Gilles-de la-Tourette syndrome. Okay. So these are the indication of antipsychotic drugs. So this completes your topic on antipsychotic drugs. Okay, different antipsychotic drugs and their uses and adverse effects. Okay, their drug interactions. Okay, so you need to compare these typical and atypical antipsychotic drugs. Now next we'll start with the antimaniac drug also. Okay, so today we'll complete the drugs for bipolar disorder also. Okay, so antimaniac drugs, that is the drugs used for mania. Okay, so mania, it is characterized by excessive desire and of too much of euphoria. Okay, so there is a pathological excitement with racing thoughts, pressured speech, and a little bit of sleep. The exact mechanism is not known, but it seems that there is a preponderance of the noradrenaline and dopamine related activity which is exacerbated in the mania. Okay, And these patients, along with the maniac episode, they also have a cyclic episode of the depressions with the normal mood in between, which is known as the bipolar maniac depressive psychosis or bipolar disorder. So the maniac episode is mainly believed to be increased level of the noradrenaline level, whereas depressive phase is mainly related with the decrease in noradrenaline level. Okay. So drugs here used are mainly the lithium carbonate, okay, which is very much effective, but also having its low therapeutic index or safety margin. Okay, these are less commonly used, and other drugs, okay, like sodium valproate, carbamazepine, lamotrigine. These are the anti-epileptic drugs and has been found to be effective as that of lithium. Okay, and along with that, other atypical antipsychotics drugs like olanzapine, risperidone, quetiapine, and aripiprazole also are used in cases of bipolar disorder. Okay, so lithium carbonate, which is a very important topic. Okay, it can be asked in the exam as for SAQs also. Okay. So lithium, it is like a sodium and potassium. It is also a monovalent cation, okay, and was found to be effective as an antiemaniac and as a mood stabilizing drug. Okay, previously lithium, it was used as a salt tablet instead of sodium in hypertensive patients. Okay, but it was found that lithium was very toxic and patients started to having toxicity and the cause of for the death. Okay, before 1960, 1970, okay, it was not there was it was not known about the maintaining the plasma level of the drug. Okay, later on, after 1960 to 1970, the importance of the maintaining the therapeutic range of the plasma level was realized, and again, the efficacy of this lithium was found to be effective in maniac patient. Okay, during this use of this lithium salt in hypertensive patient, okay, some patient was dead, but it was found that patient having maniac symptoms with hypertension, the maniac symptoms were decreased. Okay, so this was found that lithium was effective in cases of mania. But again, because of its not known about the maintaining of the therapeutic level, this lithium was not used. Once this the importance of maintaining the therapeutic range of plasma level was realized, lithium was again started to use for the mania patient. So lithium, okay, it is neither sedative or nor euphoriant. Okay, it gradually suppresses the maniac episodes, which takes around 1 to 2 weeks, and also it also normalizes the sleeping time. Now, as for mechanism of action, okay, lithium, okay, you know, okay, this is the cell, okay, having cell membrane with the G protein coupled receptors, okay. So you know there are different second messengers, okay, in cell, like cyclic AMP, IP3, okay, that is the inositol triphosphate, and diacetyl DAZ, okay, that is the diacylglycerol, okay. Second messengers, okay. So here lithium, okay, lithium, it acts on this recycling of this second messengers of IP3 and DAZ, okay, and most of the alpha adrenergic action and muscarinic transmission, they acts through these second messengers, okay, through this G protein coupled receptors or second messengers like DAZ and IP3, okay. So lithium, it inhibits the enzymes at different steps, okay, which inhibits this recycling of the IP3 and DAZ, okay. So lithium, it inhibits the inositol monophosphatase, which inhibits the formation of IP2 to IP1, okay, and also it inhibits the inositol phosphate 1 phosphatase, okay, which inhibits the formation of IP1 to inositol, okay, and ultimately this inhibits the formation of this PIP2, okay, which is the okay, and thus inhibit the formation of second messengers, that is DAG and IP3, and there will be no cellular effect. Okay, so in many patients it has been found that this actions of increasing the activity of IP3 and DAG was very high. Okay, so lithium, it inhibits the formation of this PIP2, that is the phosphatidyl inositol biphosphate, and thus inhibit the formation of IP3 and DAG, and thus there is the no cellular effect. Okay, and that will decrease the episode of the manic symptoms. Did you get that, everyone? Mechanism of lithium. Now, lithium, it inhibits at different steps. That is, that inhibits the enzyme, that is inositol monophosphatase enzyme and inositol polyphosphate 1 phosphatase enzyme. Okay, that inhibits the formation of IP1 and inositol. So that will ultimately inhibit the formation of PIP2, that is a phosphatidyl inositol biphosphate. Okay. Did you get that? Okay, so you can see in this chart also, okay, mechanism of action of okay. So you can see in this chart, okay, the mechanism of action of lithium. Okay, lithium, it inhibits the inositol monophosphate and inositol phosphatase phosphate 1 phosphatase enzyme, which inhibit the conversions of IP2 to IP1 and conversion of IP1 to inositol respectively. Okay, so that will ultimately inhibit the formation of phosphatidyl inositol biphosphate, which is the precursor for the IP3 and DAG. That is the second messengers of when G protein activated. So that will decrease the thus the effect of the transmitters on the cell decreases, as IP3 and DAG are the important second messengers for both alpha adrenergic and muscarinic transmission. Okay, that is the major mechanism of the lithium. There are other mechanisms that is also postulated, like lithium, it partly replaces the sodium, body sodium, and is nearly equally distributed inside and outside of the cells, and that will affect the ionic fluxes across the brain cells or modify the property of the cellular membrane. Okay, and also lithium decreases the presynaptic release of the noradrenaline and dopamine without affecting the serotonin release. So that will again correct the imbalance in the turnover of the brain monoamines. Okay. So other pharmacological action of lithiums, okay, apart from antimanic action, it mainly causes the diabetes insipidus like effect, okay, because it inhibits the action of ATH on distal tubules, okay, and cause the diabetes insipidus. It also has insulin-like actions, okay, on glucose metabolism. Okay, and also it can increase the leukocyte count and inhibits the release of thyroid hormones that can lead to the hypothyroidism. The pharmacokinetic property of the lithium, it is slowly but well absorbed orally, It has a uniform distribution in total body water with an apparent volume of distributions steady at average of 0.8 to 0.8 liter per kg. Then lithium is the CSF concentration of lithium is about half of the plasma concentration. It is excreted in urine with the first rapid excretion within 10 to 12 hours. However, in the later phase, okay, the half-life is increased to 16 to 30 hours. Then the steady state of plasma concentration is usually achieved in 5 to 7 days. We need to always monitor the level of plasma level of lithium. Okay. The optimal maintenance therapy for bipolar disorder is 0.8 to 0.8 milliequivalent per liter, and for acute mania it is 0.8 to 1.1 milliequivalent per liter. So more than 1.5 milliequivalent per liter will show the toxic symptoms. Adverse effects of lithium, okay, it can cause nausea, vomiting, and mild diarrhea. It can cause thirst and polyuria. It can cause fine tremors, and at high doses, it can cause CNS toxicity, okay, which relates with the coarse tremors, giddiness, ataxia. Reflexia, okay, and in acute onset, symptoms progress to muscle twitching, drowsiness, delirium, coma, and convulsions, okay, and other symptoms in high doses again can cause vomiting, severe diarrhea, albuminuria, hypotension, and cardiac arrhythmia, okay. So we must always go for the look for the therapeutic level of the lithium. Then other adverse effects on long-term therapy, it can cause diabetes insipidus, okay, weight gain, goiter development, and hypothyroidism, which is managed by the thyroid hormones, okay. At therapeutic level, it can reduce the T-wave amplitude, and at high doses, it can cause acid node and AV conduction depressed, okay. Lithium, it is contraindicated in pregnancy, which can cause fetal goiter, cardiac abnormalities like Epstein anomalies, and it is contraindicated in lactation, cause lethargy to the baby, okay, cyanosis and poor shock and poor motor reflexes. It can also cause sick sinus syndrome and can worsen the dermatitis and acne. Drug interactions with lithium, okay, diuretics like thiazide diuretics and furosemide, it can increase the reabsorption of lithium, which can lead to increased lithium toxicity, okay. Tetracycline, NSAIDs, and ACE inhibitors, it can again lead to, it can also cause lithium retention and cause increased toxicity. Lithium, it reduces the pressure effect of the noradrenaline, okay. Lithium, it enhances the insulin and sulfonylureas, which can lead to hypoglycemia, and succinylcholine and pancreatinine, which are the muscle relaxant, okay. It can this lithium with patients with treating with the lithium. These drugs can prolong its action, causing paralysis. So uses of lithium in acute mania. Usually in acute, atypical antipsychotic drugs are used, okay. After controlling this acute onset, we go with the lithium, okay, as a maintenance therapy for 6 to 12 months to prevent from the reoccurrence. Next indication in case of prophylaxis in bipolar disorder. Okay, lithium, it is gradually introduced and as maintained at the plasma concentration of 0.8 to 0.5 to 0.8 milliequivalent per liter, and again we have to gradually withdraw the drug over months. Then other indications in case of recurrent neuropsychiatric illness and non-bipolar major depression. Then the for the mania, okay, alternative to lithium, okay, because of its low therapy, other drugs like anti-epileptic drugs like sodium valproate, carbamazepine, and lamotrigine are also effective in bipolar disorder or in mania. Similarly, some atypical antipsychotic drugs are also effective. Okay, so in mechanism actions that will be discussed in detail in anti-epileptics when you are taught about the anti-epileptic drugs. Okay, epilepsy usually occurs by the repetitive firing of the brain neurons, okay, in different parts of the brain neurons. So sodium valproate, they mainly the mechanism of anti-epileptic action is that they mainly prolong the sodium channel inactivation state, okay, and also it decreases calcium activity, and also it augments the release of the inhibitory GABA transmitter. Okay, so that is the main mechanism of the sodium valproate having anti-epileptic action, that will decrease the repetitive firing of the brain neurons. Okay, so this sodium valproate, it has been found to be effective in the mania also. Okay, or in cases of bipolar disorder, which decreases the maniac relapses, and also in acute mania, high doses of sodium valproate can be given, which decreases the symptoms faster than the lithium also. It can be used alternative or in combination with the atypical antipsychotic drugs and benzodiazepines. So it can be used in those not responding or tolerating to the lithium. Also, it can be given in combination with the lithium resistance, lithium in resistant case with either of the drug. Next, carbamazepine, it is also anti-epileptic drugs. It prolongs the remission in the bipolar disorder. Okay, however, it is less effective than the valproate and lithium. Lamotrigine is a newer anti-epileptic drugs used for the prophylaxis of depression in bipolar disorder, and however, it is not so much effective in the mania. So lamotrigine can also be given in combination with the lithium. And last, atypical antipsychotic drugs. There is the olanzapine, risperidone, okay, aripiprazole, and quetiapine. This can be given with or without benzodiazepines for the first line of drugs for controlling the acute mania. Okay. However, for the acute onset, again, parenteral oral neuroleptics are preferred, and combination of atypical antipsychotic with lithium or valproate show the higher efficacy in acute phases as well as for the maintenance therapy of the bipolar disorder. Okay, so these are the drug treatment for the mania and bipolar disorder. Okay, so I think that finishes your class for today. So we have completed the drugs for schizophrenia and